Hello, everyone. I am Bob Blum. We'll do more introductions in a moment. Good morning or good afternoon, or depending on where you are, good evening. And thank you so much for joining us. Let me just mention a few things before we move into the presentation and discussion. First of all, we would ask that you keep your microphone muted except when you're going to speak, and you can ask questions. We'll have a substantial time for discussion after both Mau Lee and I present. What we would ask is that you go to the participant list. There's a place for you to raise your hand. If you want to ask a question, we can call on you and acknowledge the question. You can also go to the chat box and write your question as we go along, and we can incorporate that into the discussion as well. So next slide, please, Mau. I am the lead investigator for the Global Early Adolescence Study, and this webinar is being co-led by myself and my colleague, Mau Lee, who is the senior data analyst with the Global Early Adolescence Study based here in Baltimore. In this webinar, we're going to focus on adverse child experiences in young adolescents globally. We're going to talk about measures, how we analyze these data, and the relationship between depressive symptoms and violence perpetration. Next slide, please. So the goal of this work is to assess the prevalence of adverse child experiences among adolescents in 14 low-resource communities globally. Many of you probably are aware the Global Early Adolescence Study works in urban areas in some of the poorest sections of cities around the world. And so one question is, what do we know about adversity that young people face? We want to study how additive ACEs exposures are related to both depressive symptoms and violence. And there's a body of literature, I'll talk about it in a second, that shows in high-income countries that child exposures is related to negative outcomes in adults. But what do we know about those exposures in young adolescents globally? And we wanted to look at two ways of analyzing ACEs data. We'll elaborate on that momentarily. Next slide, please. So the way that we're structuring this webinar is we start with an overview and rationale. We'll talk about the study population and some of the prevalence of ACEs. We'll then go into data analysis, looking at two ways that we analyzed these data, report on the findings, and then the discussion and opportunity there for presentation. Let's go into the overview. Okay, so there has been a body of work that began in San Diego in the United States in the mid-1990s that shows an association between childhood exposures to adversity. And we'll talk more specifically about what we mean by that in a moment. But childhood exposures to adversity and adult negative health outcomes. And these negative health outcomes include everything from emotional problems and depression to cancer, to liver disease, gastrointestinal disease, a wide range of adversities. But there's been very little work that's been done in low income and middle income countries around the world. There's also been much less work done in the age population that we're focused on, which is 10 to 14-year-olds. But this relationship between exposures and negative outcomes, at least in higher income countries, has been shown. And we want to look more specifically at what exposures in early adolescence means for this age population. So next slide, please. When we look at the current literature, there are really four ways to analyze the data. The primary way ACEs have been analyzed is a summed or cumulative score. Going back to the original work that was done by Folletti and Anda in the mid-1990s, reported out in 1997, they added up the number of exposures to a set of adverse experiences. They sent out a questionnaire to a large group in a Kaiser Permanente clinic in San Diego, California, like 50,000 people. And then they did chart reviews. Based on the responses that people gave, they did chart reviews looking at the relationships between the number of adversities and negative health outcomes. And this became the standard of analyses that was used. But since then, there have been other approaches. Friedman, for example, used weighted individual scores. So they weighted the scores based on recency, frequency, how often it occurred, perceived impact of the adverse experience, and then they analyzed them. So a second approach isn't just summed scores, but it's weighted scores. The third that has been used by some in the probably largest global study on child abuse and neglect, the LogScan study, weighted ACEs by subgroups. So there are different component parts of this ACEs scale, and they reported that. More recently, Shin and colleagues reported typologies of ACEs using latent class analysis. And so there are really four different approaches to ACEs. And we were interested in looking at two of these much more closely. So in this present work, we're interested in looking at exposures to adverse child experiences and two different outcomes. One is depressive symptoms and one is violence perpetration. These are two significant issues in the lives of young adolescents. And we wanted to look at the relationships between those two outcomes and ACEs by looking at two things. One is a cumulative score, a dose response or exposure response approach And the second is to use an analysis similar to what Shin used, and that is to see, are there typologies of exposures that can be determined from our sample, and what are the, if there are, what are the relationships between those typologies and depressive symptoms and violence perpetration. So we started with 1,941 individual young people from around the world, and we wanted to make sure there were no missing values for ACEs exposures and for the two outcomes. And so from the overall sample, we eliminated about 250, and so our core sample then had no missing data from depressive symptoms or violence. And then we eliminated an additional approximate 400 where there were some missing responses to the ACEs questions. And then we eliminated 13 more where there were some technical difficulties in our India sample. We wound up with an analytic sample of 1,284. This is 1,284 young people living in low-income communities in low, middle, and high-income countries around the world. Our ACEs measures really fall into two categories. One is a maltreatment category, and one is household adversities. So here, in the questions that are asked, we ask about, have you ever growing up experienced a set of these outcomes? Fear of being physically abused, fear of emotional abuse, fear of physical neglect, emotional neglect, sexual abuse, and violence victimization. This is the core maltreatment questions. Most of them parallel what was originally used in the Kaiser study. And then we had a set of household adversities: parental substance abuse, parental emotional distress, ever having seen mother being beaten or treated violently, any parent having been incarcerated, and household instability in terms of enough food and issues such as that. Next slide, please. So I'm now going to turn the presentation over to my colleague, Mao Li, who will talk about the analytic approach and then talk about the analysis we did and some of the findings. Mao, let me turn it to you.
Thank you, Bob, for the wonderful background introduction. I'm taking out from the analytical approach to sharing how we did the analysis and also sharing the results from our project. In our study, adverse childhood experience is a key predictor and was treated as continuous variable based on an index calculated across all the ACES items, and also alternatively was treated as a categorical variable inferred by latent class analysis. We are also interested in two outcomes. One primary outcome is self-reported depressive symptoms, which was categorized into 3 levels, indicating no symptoms, reporting 1 to 3 symptoms, and reporting more than 3 symptoms. The secondary outcome is violence perpetration among peers, which is we treated as a binary variable. Multi-nominal logistic regression was conducted for hypothesis for depressive symptoms, and the logistic regression was applied for violence perpetration. Models commonly adjusted for sex, country of origin, family wealth index, and education attainment. This slide shows the top ranked ACEs in our study population based on its prevalence. And we can see from this slide, 5 ACEs types actually have very high prevalence. Specifically, nearly half of the adolescents reported the experience of emotional abuse, violence victimization, and household instability. Another more than 1/3 had exposure to physical abuse and emotional neglect. We were also interested to know if boys and girls had different exposures. What we are informed by these slides is that boys are significantly more likely to be the victims than girls across multiple adversities, including, for example, physical abuse and neglect, sexual abuse, violence, victimization, and exposure to parents with substance abuse history. A growing body of literature has pointed out that the tendency of co-occurrence of different adversities. Based on this evidence, we explored our study population by latent class analysis to see if certain ACEs clustered together using our sample. This slide presents 4 types of ACEs clusters based on the analysis. We can see from here clearly. Class 1 indicates observations or adolescents with low exposure to all ACEs, whereas Class D is the most severe type with high exposure to all the ACEs domains. What differentiates Class B and Class C subtype is the exposure to violence victimization, household instability, and physical as well as emotional neglect, which are circled in this box, in addition to physical and emotional abuse. Class B is defined as additionally high exposure to violence, victimization, and household instability, whereas Class C is defined as high exposure to emotional as well as physically neglect. We evaluating ACES prevalence also by the clustered type, and we do not observe a significant difference between boys and girls. As previously noted, we assessed the relationship between ACES exposure and the depressive symptoms using continuous ACES and alternatively clustered ACES. Based on the continuous ACES, we learned an exposure-response relationship with increased ACES exposure being linked to having 1 to 3 or more than 3 depressive symptoms. The association also holds true for girls and boys separately. This slide shows the relationship and its magnitude based on clustered ACES. And we can see from here, Class B, C and D types of the ACES exposure is significantly linked to depressive symptoms when we are using Class A, which is low overall exposure as a reference group. The association is much stronger indicated for reporting more than 3 symptoms per each cluster type. Latent class analysis also allows for further understanding what types of mixed ACES exposure are related to a particular outcome. In this case, we learned from the results that exposure to physical and emotional abuse and neglect is associated with a nearly 11-fold increase in the risk of having more than 3 depressive symptoms, whereas exposure to physical or emotional abuse, violence victimization, and household instability is associated to a nearly 5 times increase in the risk, both comparing to the group with low exposure across all the ACEs. The risk is significantly increased up to 29 times if an adolescent has very high exposure across all the adversities. Sex stratified results are also in compliance with what we have learned from the overall sample. Both boys and girls have greatly increased the risk of reporting more than 3 symptoms. The magnitude is especially prominent for girls with high exposure across all the ACEs, which infers an increased risk by 57 times. We then applied similar approach to assess the association between adversity and violence perpetration behavior with additional adjustment for age in the multivariate logistic regression model, considering increased likelihood of violence engagement among older adolescents. Results suggest a nearly 30 to 40% increase in the odds of violence perpetration, both among all the adolescents and also among boys and girls sampled separately. We would also like to understand how the relationship looks like among boys and girls using clustered ACES. Analysis concludes that adolescent boys and girls with Class B exposure and Class C types of exposure are more likely to actively engage in peer violence. The magnitude of the association ranges from 0.2 times to 3.8 times, but the association becomes worse if boys and girls are highly exposed to all the adversities. The magnitude of such the association is especially pronounced among boys, which reveals almost 12 times increase in the odds. We should also consider study limitations when planning for interventions. First, it is all based on the cross-sectional data, which cannot infer and causal relationship between ACES exposure and the targeted outcomes. Secondly, the association suggested by our study should only be generalized to adolescents coming from the low or middle income countries because of our sampling strategy. Lastly, we based our analysis on self-reported depressive symptoms without clinical validation. So we cannot regard adolescents reporting depressive symptoms as actually having depression diagnosis. I will switch back the mic to Bob.
Thanks, Mao. So this was a brief overview of the analyses. I think that there are a few points that are really worth making. First of all, young people who live in the poorest sections of cities around the world are exposed to very high levels of adversity. If you think about that, quite a number of the ACEs, approximately 50% of all young people in our settings indicated that they had experienced that level of fear of physical violence, of emotional violence, etc. The second point that I think is worth really underscoring is that boys consistently report more adversity than do girls. And that's true for many, many of the ACEs, including fear of sexual abuse. I think this is really, really important because the prevailing notion is that boys, because of their size or their strength or whatever else, are much more protected than are girls. But our data suggests in the context where we've been doing this work, that's simply not true, and that boys face substantial adversity. The third point that we see, and this is very consistent with the mental health literature overall from around the world, is that for girls, ACEs exposures are associated with internalized behaviors and experiences. So we see for girls a higher reporting of depressive symptoms than for boys exposed to similar level of adversity. But for boys, we see more externalizing behaviors and violence perpetration. We conclude from this work that it is really important to, in work that we do, whether it is in family planning or child marriage or in any number of focal areas, that it's really important to understand the experiences that young people have growing up as they move into adolescence. We take a life course framework approach to adolescence, in that we see this, this set of experiences in childhood having significant impact in young adolescents. The point is that you cannot take young people out of their context, and you cannot ignore the experiences they have. If you're focused on a violence prevention program, for example, understanding young people's histories become really important. We want to thank our colleague, absolutely wonderful doctoral student, Gia Narango Rivera, who helped with this study, doing background work and literature review. And we want to acknowledge our core donors, the Bill and Melinda Gates Foundation, the David and Lucille Packard Foundation, USAID, and the Oak Foundation for their support. At this point, we'd like to open it up. We have upwards of a half hour for questions, thoughts, discussion, and this can be done in any number of ways. You can jot your notes, or you can raise your hand. So I see a note from WHO. Thanks for the study. One question of clarification. Why did you decide to measure self-reported exposure to fear of two types of violence rather than exposure to violence itself? We based the development of the measure of adversity on two previous bodies of work. One that we referenced, and that is the CDC and Kaiser study that was done in the United States. But there was another important study done in Nairobi, led by Caroline Kabiru and colleagues. And I know that Caroline is on this webinar. And they developed and adapted an ACEs measure for Karagochi and the work that they do in Nairobi as well. Caroline, would you want to elaborate a bit on the work that you have done in this area? And if I can figure out how to do it, I'll see if I can give you mic privileges.
Hello, can you hear me?
Yes, I hear you clearly. Perfect.
Thanks. The questions that we had used were taken from a study that had been conducted in the US, and then we also pre-tested it in the slums of Nairobi. And this was The reference is a paper by Dubé, looking at adverse childhood experiences and the association with ever using alcohol in the United States. But then, like I said, we did adapt some of the questions to the local context. And I could quickly go through the questions that we asked, if that's useful, Bob.
Sure.
Sure. So one of the items we looked at whether in the last month families did not have enough food, because we know that household food insecurity is quite high. We also looked at whether families had suffered because parents were out of a job, knowing that many of the adults in our settings work in the informal sectors. We looked at whether young people lived with someone who had problems with alcohol, whether parents had ever divorced or separated, lost their home because of a disaster, again, which is common in the slum settings. And then some of the other items that Bob had talked about, witnessing a mother or father being a mother figure being beaten, being kicked out of a home by a parent or guardian, living in a home where a parent or an adult had inflicted injury on them, and then the rest were some of the personal experiences around sexual harassment and sexual abuse.
Thank you very much. That actually links directly with the question that Courtney raised. And let me turn this over to Mau Mau. Do you want to talk about more specifically what the violence exposures were that we looked at?
Sure. Thank you, Courtney, for your question. So in our study for violence, including perpetration and victimization, the items we are used from the survey are measuring the peer violence. So for example, the item saying, have you ever been slapped, hurt, or physically beaten by your peers in the last 12 months? So that's basically is the demo question or items we used to develop the variable for violence victimization as the ACES measure. For outcomes, violence perpetration is just a turnaround of the question by saying, have you ever slapped or physically hurt your peers in a way that they do not like? So so that's how we construct the variable for the outcome.
Thank you. We have another comment or question from Rinko. Hi, Rinko, who's in Burkina. There was a study done in the United States on the effects of family strengths and childhood adverse events on adolescent pregnancy. Have you looked at this study? I'm thinking about doing a similar analysis with GEAS in Cape Town. The specific study that you are referencing, I'm not, I don't know that specific study. I am quite familiar with research that has been done. And let me back up. As I said earlier, that there's a fair amount of research, a large amount of research that looks at childhood exposures and subsequent adult outcomes. And one of those adult outcomes in later adolescence is adolescent pregnancy. So that relationship has been looked at. And the measures are pretty comparable. As far as I know, in no low income community has there been an exploration of the relationships between ACEs and adolescent pregnancy. The issue becomes in doing that, you need probably an older sample of adolescents than we currently have in the GEAS. In most sites in the GEAS, because our population is 10 to 14 years of age, we have very low reported onset of sexual intercourse and very, very low reported pregnancy rates. But if you have a population who's 15 to 19 years of age, and then you can look at adversity, you definitely could look at those relationships, much as we have done with depressive symptoms and violence perpetration. Is there, Mau Mau, anything else here that you would want to add?
I think that's very comprehensive.
Okay, and Rinko, we can easily share Caroline's study. We will post it. It is one that had great impact in informing all of our ACEs work. And when Caroline was at the African Population and Health Research Center, she was one of our core and initial collaborators. So we definitely will do that. Will we be willing to share the questionnaires and tools? The answer, Laura, is you bet we will. First of all of our measures in the Global Early Adolescence Study are posted on our website. We give them away. They're there to be used, and we would really encourage them to be used. Secondly, this presentation, this webinar, will be made available. And then thirdly, if there's anything else additionally that you would want, please just email us and let us know, and we will follow up with you as well. Let me turn to Miriam Hartman's comment or question. As someone who's been working with community-based mental health organizations in Cape Town, Waves for Change on gender equality, I've been particularly interested in gender differences in terms of mental health presentation and related exposure to ACEs. So it's great to see your analysis in that regards. Do you have any further recommendations on research questions that need to be related to ACEs or mental health outcomes by gender? I would lead off and then turn it to Mau Mau, and really anyone else who is on this call can respond as well. So in the GEAS, we have a number of questions that explore violence, interpersonal violence, bullying, sexual, physical, emotional violence. We also explore relationships and as protective factors, and we look at it by gender. So the protective factors are dimensions that I would suggest for anyone working more substantively in this field that are really worth looking at. Caring and closeness to parents, to other adults, the protective roles of peers, of schools, etc. And these are all questions that are embedded in the GEAS. Mau Mau, additional comments or questions here?
And also one comment for regarding the protective factors when doing the ACES. And also there's some literature in the field suggests in addition to the family structure or supportiveness, and also religiosity could be used as a buffer for the ACES as well. So I suggest in your future project, you can also incorporate the religiosity to see how it affects the relationship between your key exposure and your outcome.
I think that's a terrific suggestion. Very rarely is religiosity included. And we know from just experience that it is important in the lives of young people. We tend to look at religiosity from a research perspective from two dimensions, and that is private and public religiosity. So private religiosity, an example would be prayer. How often do you pray? Public religiosity is going to church or a mosque or temple, and that's much more an outward perspective. So including those dimensions would be quite useful. Both Rinko has posted the citation for the teen pregnancy, and Caroline the link with her seminal article there. So that's, I think, very useful. In war situations such as Yemen, how can we maintain the ACEs in an accessible level? I think that war exposures provide unique and extremely painful and problematic consequences for young people. There is a large and growing body of work of the consequences of war and conflict on adolescents. Some of this came out of Mozambique from work done 20 and 30 years ago. Neil Boothby, who is now at Columbia University, has done landmark work and followed young people exposed to the violences in Mozambique over a 25-year period of time. And those lasting scars are profound for child soldiers, for those who were not directly involved, but indirectly involved through starvation and food restriction, who witness parental murders, etc. The consequences there for emotional well-being and for health are well described. It has been well described going back to the Dutch famine winter of 1944, of the consequences to the offspring of women who experienced food restrictions and starvation as a consequence of war. And we know that those consequences are substantial as well. Anything that can buffer those exposures makes a difference. And when I say anything, that anything can be nutritional, that anything can be a caring adult in the lives of a young person that can provide some buffering in war experiences. But the consequences in a place like Yemen that is experiencing significant national adversity is pretty profound. Anything anyone else would want to add on that topic? I don't see anything else there. Any other comments or questions that people have or would want to bring up at this point? Are there other webinars planned for this year? Let me go to that after Caroline's comment. Research on mental health interventions. Very good point. There is work that's done on community mental health interventions, not just individual mental health, but community mental health strategies, and using lay people, such as teachers, such as faith leaders, in terms of providing mental health services. So thank you for that comment. There are other webinars that are planned, but not for this calendar year. So we recently returned from Kigali, where there was the International Conference on Family Planning. The GEAS did a number of analyses in preparation for that work, and we will be organizing in the first quarter of 2019 1 or 2 webinars around that work. Additionally, we are planning a webinar, the date hasn't been set yet, on ethical issues of research with young adolescents. And this too was linked with with a panel that was organized for the GEAS pre-conference at Kigali, and we'll be doing a webinar on that. So we'll be sending out more information there. From Courtney, I think you mentioned adapting the ACEs items going forward. Do you think there's an adaptation necessary when expanding to a global context? Well, as we noted, this work has been done now in a global context. What I would suggest is that we have a core set of questions that seem to work quite well, and we can then, I would suggest, build on that for context-specific kinds of questions. Can we send our email? So my email is very simple, and if it comes to me, I will make sure it's distributed to whoever can best answer. My email is rblum, R-B-L-U-M, at JHU, Johns Hopkins University, .edu, education. So rblum at jhu.edu. But we'll also, when we distribute this, send out the connection for both Mau Mau and myself. Not seeing any further comments or questions, I think that we can wrap up this webinar. We hope that you'll go on our website and look at the measures much more closely, and look at this webinar in more detail. And of course, if you have comments or questions, please just raise them with us, and we will be very enthusiastic to respond. In the meantime, have a good day or evening, and we look forward to continuing to work with you as we look to improve the health and well-being and outcomes for all young people around the world. Take care.